So today I wanted to go through diabetic eye disease and the retinal vascular occlusions, and we'll sort of see where we get to, but hopefully we'll be able to get through both. So we're going to talk about retinopathy and maculopathy. I think it's important to look at those two things as separate conditions because you treat them differently and they can also sort of react differently to treatments. And then we're also going to talk about vein occlusions and artery occlusions as well. So we're just going to get stuck in. So with diabetic eye disease, it's a leading cause of blindness, especially in the working population. And the main sort of things to think about here are both the retinopathy side of things and the maculopathy side of things. So with retinopathy, you're looking at the sort of type of diabetic disease they have. Is it type 1 or 2? How long have they had the disease for? How is their glycemic control? Pregnancy can also impact the speed at which this progresses. Um, and then with the maculopathy, what people sort of ignore is that actually, or sometimes anyway, is that maculopathy is actually the main cause of severe sight loss. The retinopathy can cause problems in terms of vitreous hemorrhage. You're going to treat it with PRP that can sometimes cause issues with your peripheral field. But the maculopathy is actually the main cause of severe sight loss in diabetics. The other thing to consider is cataract. So in diabetic eye disease, cataract tends to present earlier. It's you tend to get your sort of PCO type cataracts, um, sorry, PSC, and you also post-operatively have increased rates of endophthalmitis. And the other thing to remember with cataract in diabetic eye disease is that the mainstay of diabetic eye disease is routine monitoring. So if your cataract starts to get into the way of being able to assess the retina, then that would be a reason for earlier cataract removal compared to some other patients. And the thing to have in the background are your sort of landmark studies that looked at tight glycemic control and how it impacted the retinopathy and the progression of it, and how both in type 1 and type 2 diabetics it showed a reduction in retinopathy. But bearing in mind that in severe diabetic retinopathy, if you were to start managing things really tightly straight away, you can actually sometimes cause a progression in their retinopathy before a regression. And then the Accord showed very tight glycemic control. So with DCCT and UKPDS, you were looking at HbA1Cs around 7 to 7.5%, whereas your Accord was looking at about 6%. And actually, they stopped that early because people started dying for other reasons, which we're not really entirely sure of why. So that's a sort of background on diabetic eye disease. Um, Looking at the diabetic eye and how you want to assess these patients, you want to take a very good history to begin with. So you want to look at how is their diabetes being controlled? Is it oral medication? Do they need insulin? What sort of other past medical history do they have? Do they have any other cardiovascular risk factors? And then the ocular history. Have they been treated for diabetic eye disease before? Are they phakic? Do they have any other eye conditions? Do they have glaucoma? And you also want to know what they're doing for work. Because actually, when you start to treat diabetic eye disease, especially with PRP, you may start to cause problems with their field. And if they're a driver, then that's a discussion that needs to be had with their patients. Then you're going to obviously just do a normal examination. What's their visual acuity? This can sometimes be much lower than expected, which gives you a sort of clue as to whether or not they have a lot of ischemic maculopathy. You're going to look at their anterior segment. Their cornea can be less innervated. They can have corneal desensitization. That sort of then predisposes them to non-healing ulcers. Do they have any NVI? Do they have any cataract? You're looking at their retina. You're looking at their macula. Do they have a tractional retinal detachment? Are they very ischemic? Do they have any signs of new vessels at the disc? Do they have a papillitis? These are patients that are at risk of ischemic optic neuropathy. So you're kind of looking at the entire eye when it comes to assessing the diabetic eye. Don't sort of narrow yourself down just onto the retina because there are other clues that you can get that this is a very ischemic eye or it's a patient that's at high risk of progression. So do sort of consider the entire eye when looking at these patients. Then you're going to sort of narrow down on the fundus. So for retinopathy, you're looking at both background pre-proliferative and proliferative disease. And then for maculopathy, you're also then going to look at whether or not you've got focal or diffuse maculopathy. Do they have clinically significant macular edema? And do they have diabetic macular edema that is focused at the fovea? So with background retinopathy, you're just looking at a few microaneurysms, a few hemorrhages, and I've got some pictures to show you what this looks like. Your pre-proliferatives, you're looking at things like multiple dot blot hemorrhages, venous beading, ERMA, and these also gives you clue as to whether or not they're high risk pre-proliferatives. Are they patients that are more likely to progress into proliferative disease? And your proliferative disease is then looking at new vessels at the disc and new vessels elsewhere. And then your maculopathy could be either a focal area of maculopathy within the macula, diffuse across the macula. Are they ischemic? Clinically significant macular edema. So these has certain definitions. Again, I'm not going to go into the exact details here, but you can sort of read them up. It's just about rote learning the three definitions of clinically significant macular edema. And then is it center involving diabetic macular edema, in which case the treatment will be slightly different. So with diabetic retinopathy, over here, what you can see is a background diabetic retinopathy. So this first circle here shows you what a microaneurysm looks like. So it's a very small dot, very well demarcated. It doesn't look sort of diffuse. It's not got weird margins, whereas your dot blot hemorrhage does. So it's a slightly more sort of irregular shape. It's not so small. And that's the difference between the two. And when you start to get like 8 or more dot blot hemorrhages in all the quadrants, you're starting to look at a sort of pre-proliferative eye rather than just a background retinopathy change. Now, this is your sort of very high risk pre-proliferative. So this first circle here shows you what venous beading looks like. So you've got beading along the vessels, and that can sometimes be very definite or can sometimes be very, very obvious. And then you've got ERMA. And the best way to think about ERMA is a sort of it's vessels between vessels, and you're sort of getting these lines, these connections between other vessels. And these are again a problem. These are problematic in that a single ERMA gives you a high risk pre-proliferative patient, in that these are patients that can progress to proliferative disease. And then you start to think about your proliferative disease. So these are patients. So if you can look at the difference between ERMA, so here your ERMA are sort of these single like weird twig-like vessels, whereas your new vessels and proliferative disease tends to be more fronds. They're sort of fan-shaped and they're a bit more organized. So this is your classic new vessels at the disc, and this is your new vessels elsewhere. Now, the higher risk proliferative diseases are when your new vessels at the disc are over a third of a disc area, or it's any new vessels at the disc associated with a pre-retinal hemorrhage. So if you go back to this picture, this is clearly a new vessels at the disc that cover a larger than a third of a disc area. So if you look at the disc area here, you've got new vessels at the disc that actually cover roughly maybe 2 to 3 disc areas. So this is a high risk pre-proliferative. And then when you look at the new vessels elsewhere, it's any uh, new vessels that cover half a disc area. I'll just need to edit that. Half a disc area, and then that's associated with a pre-retinal vitreous hemorrhage. So if this patient only had this area of new vessels, there's no pre-retinal hemorrhage. Let's ignore this new vessels at the disc. This would have been a proliferative disease, but not a high risk proliferative. Now, the difference between the two are sometimes in terms of how eagerly you're going to laser them, and when you're going to laser them. Proliferative disease needs to be lasered within 2 weeks, but you might have a patient sat in front of you that says, actually, I'm going to get you on the laser machine today. And so, sorry, I just brought this patient up. So this new vessels at the disc is definitely a high risk proliferative disease. Then you've got your maculopathy. So your maculopathy, so I'm not sure how well this projects on your own screens, but looking at this top picture, you've got some exudate near the center. And then you can also see the thickness heat map that while you don't have central diabetic macular edema, you've clearly got some thickening within this half a disc area. So this is your sort of classic clinically significant macular edema. But then you've also got center involving diabetic macular edema. So these are patients the way you can see lots of cystic spaces. You've got some subretinal fluid, intraretinal fluid. And again, we'll do some sessions where we look at some OCT diagnoses and how to actually look at an OCT scan. But this is a patient with center involving diabetic macular edema, and then you'd have a thickness map. And anything above 400 microns, you're going to suggest some anti-VEGF treatment. But the NICE guidelines have changed recently. That sort of kind of the way the wording has now changed is even if your diabetic macular edema is less than 400 microns thick, you can still consider anti-VEGF therapy in these patients. So then how do you manage the diabetic eye? You're going to want to talk about systemic management first. So these are patients whose sugar control needs to be sorted out, any blood pressure, any cholesterol, all of this needs to be sorted out. Education is really important. A lot of these patients don't understand the severity of this disease and how life-changing it can be. So you really I know it's hard in busy clinics, but it's worth taking the time to educate these patients or at least get them in touch with different ways of education. So either with an ECLO if you've got one, like an eye care liaison officer if you work somewhere that has one of these, or even just getting them in touch with things like Macula UK or just reading material in order for them to understand the severity of their disease. Smoking cessation, exercise, these are all things that contribute to the progression of diabetes, which also then translates to the progression of diabetic eye. And just a quick note on those with pregnancy is even without any diabetic eye disease, if you then get pregnant and you're diabetic, you can then start to develop it and it can progress relatively quickly. So if they're normal at the initial screening, then they can carry on with normal screening. But if you're noticing any diabetic eye disease, they can get an additional eye screening at about 16 to 20 weeks. Otherwise, they're seen twice, a bit earlier at about 12 weeks and a bit later at about 24 to 26 weeks. So you can give them a middle sort of screening if they show any diabetic eye or if they're high risk because they've got poor diabetic control. So how are you going to manage the retinopathy? With background disease, these are usually patients who can be discharged back to community screening. With the pre-proliferatives, you're probably going to want to see them every 4 to 6 months. Your proliferatives will be treated with some laser. If they've been treated and they're now controlled, they can go back to 4 to 6 monthly reviews. But if they progress with rubeosis and they start to develop NVI, NVA, so new vessels at the iris or the angle, you'll want to treat these aggressively with laser. They might need a vitrectomy if they've had a vitreous hemorrhage. They might need their pressure controlled if they've developed neovascular glaucoma. So it all depends on how bad their diabetic eye disease in terms of how often you're going to be bringing these patients back. And then with laser, this is typically what it looks like. You're going to get really good coverage all the way up to the disc temporally, nasally, sorry, and then all the way up to the arcades. And then temporally, you're going to have approximately from the fovea about 3 disc diameters, and that's where you want to come up to with your laser scars. Then the maculopathy. These are patients that can either benefit from focal or grid macular laser, depending on how diffuse their leakage is. But if they have center involving diabetic macular edema, these are patients who are not obviously going to be able to laser them. So you're going to want to offer them either anti-VEGFs or steroids, and we'll talk about the different types in a moment. And if they're completely ischemic with no leakage, these are patients, unfortunately, you just have to essentially observe them and let them know that there's very little that can be done, sadly. And this is where you're going to get the more dramatic drops in visual acuity. So rather than having your 6.9s and your 6.12s, these are patients that can drop to 636, 660 because of the ischemia. So macular laser, I found a picture that shows, so you've got some focal so in picture A, you've got some focal maculopathy, just infratemporally from the fovea, and you can treat this with some focal laser. Or you've got some more diffuse maculopathy where these are patients that will get some more grid laser. Now, you'd have to be quite confident with your laser in terms of how close you're coming up to the fovea here. Most people that I've spoken to, most consultants like to leave a disc diameter. Um, uh, from the fovea. Um, and the other thing as well is to bear in mind is sometimes by lasering them, you can almost cause an exudate to come closer to the fovea. So bear that in mind, and that if your exudate is already very close to fovea, you can sometimes cause that exudate migration, which actually then causes a drop in vision. So it's definitely about balancing your decision making when it comes to whether or not you're going to laser and how aggressively you're going to laser a patient's macula. Your intravitreal treatments, so your anti-VEGFs, you've got things like Avastin, ranibizumab, which is Lucentis, aflibercept, which is Eylea, and faricimab, which is Vabysmo. And again, what you're going to use depends largely on what your center has, and there are some things to consider. I'm not going to go into the details here about how aggressive the disease is, about how bad your macular edema is, about how they've responded to other treatments. And then for those who've not responded to anti-VEGFs, you can use steroids, or for those for whom anti-VEGFs are um, contraindicated for whatever reason, then you can use some steroids. Now, to bear in mind with intravitreal steroids, is you're going to want to A, consider what their pressure is doing, and B, whether or not they have a cataract. So most of the time you will be told that these treatments are contraindicated in those who are phakic, but obviously if you can't use an anti-VEGF, you're going to do what you need to do. And if they then have their cataract removed, then remove their cataract. I've worked with some consultants who, as soon as a patient starts receiving intravitreal injections, they basically have a discussion about just getting rid of the cataract sooner. And Ozurdex and Iluvien are both intravitreal steroids. They last different lengths in the eye. And again, I'll let you go and kind of go and explore those. And depending on where you work, you'll have different things available to you. Rubiosis, just a final conversation about this. So, rubiosis is a sign of it. You have a very ischemic eye, yeah? So, you've got vessels growing at the iris. This is an eye that is desperate to get oxygen to it. And that's why you're getting these vessels grow along the angle or along the iris. Now, new vessels at the iris itself doesn't necessarily cause glaucoma. It's more the vessels at the angle that are problematic. But these new vessels at the iris can bleed. They can cause hyphemas, and then that can also cause an increase in your pressure. And new vessels at the angle can essentially mimic angle closure. And these are patients whose pressure can increase very, very quickly. They can rapidly progress to glaucoma. And neovascular glaucoma is an incredibly difficult glaucoma to manage because these are patients who don't necessarily respond well to drops. These are patients who, for example, if you then PRP these patients and you cause the vessels to fibrose, their glaucoma can then progress really, really quickly. And these are patients who inevitably need surgical management of their glaucoma. So again, I've worked with some consultants who, if they're going to PRP and neovascular glaucoma, they essentially at the same time list them for a tube because they almost inevitably will need one. Um, so do consider both the diabetes and the glaucoma and the pressure when it comes to these patients. A final comment on the screening program in the UK. So anyone in the UK over the age of 12 with diabetes is going to be screened, and the screening program essentially screens them every 6, 12, or 24 months, depending on how on the council where your screening program is taking place and how well connected they are with the secondary the hospital eye screening, the hospital eye services. And these are essentially graded as R0, so no diabetes, no diabetic retinopathy or maculopathy. R1 is background retinopathy. R2 are your multiple blot hemorrhages, beading, ERMAs. And then R3 is anyone who's proliferative disease. And then your maculopathy is either split into no maculopathy or maculopathy. And then the ones that you're going to refer into secondary care, that's R2, R3s who are fast tracked. So that should say M1. Sorry, and then the unaccessible. So patients with cataracts or patients who, for whatever reason, are not able to be assessed in the diabetic eye screening program. So because of mobility or whatever it is. And importantly, the diabetic screening program also, so 10% of all pictures taken with the screening program are then sent to be assessed by a member of the hospital eye services as a sort of auditing tool to make sure that patients are not being missed. So that's the sort of run through of diabetes. It is a very sort of multifaceted disease, and these are patients who are going to need to be treated both on a systemic point level and an ocular level. And you always need to remember how the diabetic eye disease feeds into other ocular problems. So these are patients who are more at risk of retinal occlusions, more at risk of glaucoma, more at risk of um, things like cataract, for example. So you can't just sort of tunnel vision your way to the retina. You do need to consider how their diabetes is affecting A, their eye, and B, their life. And that's what makes it really difficult sometimes to manage in clinic. And it's a very chronic disease. You get to know these patients quite well, especially the ones that are coming in with treatment. And then once their retina starts to fibrose, or if they start to have tractional retinal detachments with vivovascular membranes, these are patients who are then going to need vitreoretinal surgery. So it's really multifaceted, and it's very involved, especially with the severe disease. And sometimes you do really need to kind of give patients the time um, to actually understand their disease. And these are patients who at a very young age can lose their vision quite substantially. So don't underestimate how aggressive diabetic eye disease can be. And there isn't necessarily always a correlation with how well the systemic control is versus how well the ocular control is. Sometimes patients are just unlucky, and even with good systemic control, they still progress quite rapidly. Um, so do sort of give it time and give it good attention. So we'll move on to the retinal vascular occlusions. I think so. These should be thought of as separate conditions in terms of whether or not it's a vein occlusion or an artery occlusion. And that's largely because they have very different etiologies and they can be very much raise different red flags systemically if you see them. And especially with artery occlusions, they can be signals that there is a life-threatening systemic disease that hasn't been treated. So if you think of your retinal vein occlusions, these are much more common. They can occur pretty much in any age, but the vast majority occur in those over 65, and they tend to be thrombotic in cause. So they're local thrombosis. Whereas your retinal artery occlusions is an ocular emergency, and they tend to be more embolic in cause. So there's a usually more of a systemic thing that is causing emboli to be shot off and come into the artery and block the artery in the eye. So they're slightly different etiologically, which means the red flags are slightly different. So do treat them a bit differently. So with vein occlusions, especially when you're considering your central vein occlusions, um, when you're deciding whether or not something is ischemic or non-ischemic, that isn't necessarily always obvious from an examination point of view. So your VA is a good marker. The worse the VA, the more likely you're dealing with an ischemic CRVO. Do they have an RAPD? How bad are their cotton wall spots? So cotton wall spots are a sign that you can see in almost any ischemic retinopathy. So things from diabetes, hypertension, vein occlusions. And the way I've always been taught to think about them is cotton wall spots in the context of diabetes is a very soft sign. They don't necessarily mean much. They're not necessarily a red flag in terms of the progression of your diabetes. But in vein occlusion, cotton wall spots are more of a hard sign. So if you're seeing cotton wall spots, if you're seeing that ischemia in the context of a vein occlusion, you're a bit more worried about that eye. Do they have macular edema, which is going to cause more in the way of visual acuity changes? Do they have neovascular glaucoma? Again, that's a sign of a very ischemic eye. Then you want to consider the etiology. Why has the patient in front of you gotten this CRVO? It's most commonly atherosclerotic. So these are patients who are either hypertensive, or they have diabetes, or they have, for example, glaucoma or hypercholesterolemia. That's the reason. Or you're looking at hematological causes, i.e., do they have a thrombotic problem? Do they have an inflammatory condition in the eye? Do they have a retinal vasculitis? Are they on an oral contraceptive pill? Is that the reason that they've had it? Or, like I said, the ocular causes. So, do they have glaucoma, for example? Is that the reason that they've then developed a CRVO? And then your investigations are as per your cause. So these are patients who are going to get their blood pressure checked. They're going to get their blood sugar checked. They're going to get their blood cholesterol checked. You're going to send off a thrombotic screen if you think that this is a patient that is, do they have a history of miscarriages? Do they have a history of DVTs? Is this a patient that needs a systemic thrombotic screen? And you're going to work with the primary care provider in making sure that this screening is being followed up and then being managed appropriately. This is what your typical CRVO looks like. So you've got tortuous, dilated vessels. It's in all four quadrants. You've got your dot blot hemorrhages. And this is your sort of classic CRVO. Your BRVO is, sorry, before we go into BRVO. So with your management, it largely depends on the ischemic status and the prognosis. A lot of these patients, if they're non-ischemic, you just sort of monitor them and you watch them. If they then have macular edema, you're then going to start offering anti-VEGF treatment. You might consider intravitreal steroids. If they start to develop things like neovascularization, either in the retina or in the anterior segment, you're going to PRP them. Have they developed neovascular glaucoma? Do they need a cyclodiode to try and bring that pressure down? And neovascular glaucoma, like I said before, can then really progress quite quickly. And then suddenly the patient in front of you just has a blind eye. And then that's about comfort control. So when you've got a blind eye in front of you, you have a painful blind eye, you just want a pressure control in order to keep their eye comfortable. If their eye is comfortable at 45, you don't need to worry about that. If their eye is painful at 45, then you want to bring that pressure down. That might be in the form of a cyclodiode, it might be in the form of a surgery, but remember the reason you're bringing that pressure down is for pain. So if the pain is managed, then you don't really need to worry about the pressure. And I think there's something in the realms of about a 7% risk of a CRVO happening in the other eye. So you do need to make sure that the patient is systemically well controlled. So looking at your BRVOs and your hemiretinal vein occlusions, with BRVOs, they're most commonly supratemporal. And to be honest with you, you're sort of thinking about these things in the same way as a CRVO. So you're kind of considering it's the same sort of causes, you're going to investigate the same way, and you're essentially going to manage the same way. Um, And with these things, you're sort of going to consider the ischemia a bit differently. So from an FFA point of view, with a BRVO, your ischemic risk is more with like FISC 5 disc diameters of ischemia, whereas with your CRVO, it's 10. So it's just your measures are a bit different. Um, and your complication rates are sometimes a bit lower. And sometimes with a BRVO, you can basically get away with just observing them for 2 years and then discharging them. And these are pictures of what your A. So at the top you've got a supratemporal BRVO, and then at the bottom you've got an inferior hemiretinal vein occlusion. Um, and just to comment on hemiretinal vein occlusions, the way these are sort of thought about, it's difficult. Your vein occlusion can either happen behind your lamina cribrosa, which basically means that it's a variant of a CRVO, or it can happen in front, which means it's a variant of a BRVO. That's more of an academic conversation, and actually clinically, sometimes it's really difficult to know where your clot is, but largely your management is basically the same. Then moving on to your artery occlusions, these usually have a much more dramatic loss of vision, especially with a central retinal artery occlusion. These are patients who usually have less than counting fingers vision. They have a RAPD. You've got that classic cherry red spot on your examination. And in the acute setting, you're dealing with an ocular emergency. You must consider GCA, especially in the elderly. So you're looking at for an ESR, you're going to send off a CRP, you'll look at a clotting screen, you'll send off a vasculitic screen. These are patients who you need to consider, is syphilis a potential cause? Do they need their cardiovascular risk factors looked at? You need to look at this as a stroke. So these are patients who are going to be sent off to a TIA clinic, for example, if you work somewhere that has one, but they definitely need a stroke workup. You'll be giving them some aspirin. Now, the acute treatment, there is very little evidence in terms of ocular massage, giving them some IV Diamox to try and reduce their pressure within the first 24 hours. There's little evidence, but you can try it. And these are unfortunately patients with very poor prognosis. Now, conversely, when you're thinking about CRAO versus CRVO, your CRAO, you have a completely dead retina. So you don't have much of an ischemic drive. You don't have much VEGF being released because there's nowhere to release it. So you don't typically, in the way that you do with CRVO, get your ischemic changes in terms of neovascularization and neovascular glaucoma, which I suppose is one benefit. But the problem is that you have just a um, dramatically reduced vision. And this is your typical CRAO picture. So you've got a very white, swollen, pale retina, and you've got this cherry red spot in the middle. Then you've got your branches. So you've got your branch retinal artery occlusion and your ciliary retinal artery occlusion. And your investigation and your management is still largely the same. But with a BRAO compared to a CRAO, GCA is very, very rare as a cause of this, which is why when you're dealing with a branch retinal artery occlusion, you're less likely, in the elderly, for example, you're less likely necessarily to start thinking about vasculitities and GCA as a cause. And you can sometimes get away with, unless there's a reason to think about it, only be looking at cardiovascular risk factors in the acute setting. And then that picture at the bottom is your ciliary-retinal artery occlusion. Now, weirdly enough, you're either lucky or unlucky. So either you've had a CRAO in the context of having a ciliary-retinal artery, in which case sometimes your central vision is preserved, or you're the 10% that has one, and then you're incredibly unlucky in having the ciliary-retinal artery occluded, which then means you dramatically drop your vision again because it is your macula that's being um, starved of oxygen. And then lastly, you've got this thing called an ophthalmic artery occlusion, which is the entire ophthalmic artery. Now, the problem with that is that you've not just got the retina being affected, you've then also got the choroid, which is why you then get a very, very pale choroid as well. And you kind of lose that cherry red spot because you lose that choroid behind the retina. And the entire eye has essentially been starved of oxygen. I wanted to sort of comment on ocular ischemic syndrome. Just a final comment on this. Sorry, just on conversation on ciliary-retinal artery occlusions in terms of the management. These are patients who are going to have to be managed from a systemic point of view. And if they then develop macular edema secondary to retinal artery occlusions, again, the treatment is very similar. So you're looking at anti-VEGFs, you're looking at PRP. So for BRVOs, who then develop NVEs in that sector. These are patients who are going to get sectoral PRP rather than pan-retinal photocoagulation. These across the whole retina, these patients are going to get it more sectorally across the arcade that's been affected. So lastly, with ocular ischemic syndrome, this is essentially hyperperfusion to the eye. Now, it's usually due to carotid artery stenosis, for whatever reason. So either that's kind of stenosis from an atherosclerotic point of view, or you've got some tumor that's reducing the perfusion to the eye. And these are patients who, over several weeks or several months, were slowly, gradually reducing their visual acuity, again, due to ischemia. Or these are patients who are going to come in with their amaurosis fugax. Now, just to comment on that, when you've got patients coming in with these weird visual obscurations that last less than 5 minutes, that's your sort of concern. And things going black, a complete blackout, is more concerning as a sign in terms of amaurosis fugax. So when a patient's coming in telling you, oh, I get these weird shapes or these weird colors, that is less likely ischemic in nature. You're more likely looking at things like visual obscurations due to whatever reason or potentially ocular migraines. But when a patient is sat there telling you that things go completely black, that's slightly more concerning. And typically, amaurosis fugax or ischemic loss of vision lasts less than 5 minutes. So they're very, very quick. They come and go. Whereas your migrainous visual obscurations last a lot longer. So you're looking at 15 minutes up to an hour. Your ischemic ones don't tend to last that long. It tends to be sort of very quick in their nature of coming and going. And the ocular findings, you have both anterior segment findings and posterior segment findings. So anterior segment findings, it's signs of ischemia. So you've got flare. You don't typically get cells. Flare tends to be more of a problem. You've got these proteinous leakage in the anterior segment. You may get new vessels at the iris. And then your posterior segment, you've got dilated vessels, hemorrhages, cotton wool spots, new vessels at the disc, new vessels elsewhere. What this is essentially teaching you, and what I've essentially showed you across this whole section, is that ischemic eye disease looks very similar. So diabetes, it can look like a vein occlusion. It can look like radiation retinopathy. It can look like ocular ischemic syndrome. So when you're examining these eyes, you want to examine them in the context of the patient. Diabetic eye disease tends to be symmetrical. You tend to see the disease at similar stages across both eyes because it's a systemic disease. Your CRVOs, your BRVOs, your artery occlusions, your ocular ischemic syndromes are less likely to be bilateral. They tend to be unilateral disease. And the CRVOs, again, it looks a bit more sectoral. You may not have necessarily an anterior segment finding. So a lot of this is in the context of what you're looking at. So when you're looking at a CRVO, even though you may have a CRVO in front of you, these are patients who may then end up getting carotid Dopplers because you're considering whether or not the diagnosis is ocular ischemic syndrome. And ocular ischemic syndrome, the way I've always thought about it, it's almost like seeing a pre-proliferative diabetic, but just in one eye, and the other eye seems completely fine. That's a bit of a red flag because it's obviously not a CRVO. It's obviously not a BRVO. It just looks like a pre-proliferative diabetic. You've got lots of hemorrhages, maybe some cotton wool spots, and maybe some dilated veins, but the other eye is completely fine. That is far less likely to be diabetic, even if the patient is diabetic, because you're more likely to get a bilateral disease. So when you're thinking of this, or if you're in an exam, for example, and you're seeing a patient with these changes in the back of the eye, the differentials that you're thinking about are diabetic disease, hypertensive retinopathy, which we've not spoken about, vein occlusions, and ocular ischemic syndrome, and radiation retinopathy, because all of them stem from ischemic states in the eye. And ischemic states look very similar, but they are very different in their etiology. And that's why it's important to consider all of these things as differentials. These patients are going to get FFAs and an OCT. The FFA can really give you an idea of how ischemic the eye is. You might see some delayed choroidal filling, especially in the context of ocular ischemic syndrome. And that's because the carotid artery is affected. So you're getting delayed filling to the back of the eye, which you don't typically get with things like diabetic disease. So that's how you can use your FFA to tell the difference. And carotid Dopplers is, again, to look at that stenosis. These are patients who typically have stenosis above about 90%. And the treatment for those who have the stenosis are obviously going to go down to our vascular surgeons to get endarterectomies. But then the ocular treatment will also then depend on how it progresses. So if you have NVD, NVE, these are patients who are going to get PRP. Do they have macular edema? Are they going to get anti-VEGFs, etc.? So the treatment is very similar, again, for these ischemic states. But what's important is that the ischemic states suggests a systemic problem. And if you're not going to fix the systemic problem, you're just going to be chasing your own tail when it comes to treating the ischemic state in the eye. Okay? So just as a summary, we've spoken about diabetic eye disease. looking at retinopathy separate to maculopathy. While maculopathy tends to be more of the problem in terms of your VA and practical effects of diabetic eye disease, diabetic retinopathy tends to be what you're going to see more of and what you're going to be more involved in terms of the treatment. With retinal vein occlusions and retinal artery occlusions, again, important to look at separate conditions because your retinal artery occlusions tend to be more red flaggy in terms of systemic disease that needs to be treated urgently, whereas your vein occlusions tend to be what you're going to see more of, but the ocular problems tend to be more of your concern. And then lastly, with ocular ischemic syndrome, considering that this is potentially, someone sat in front of you who is, you know, a few weeks away from a stroke. Yeah. So again, these are patients that you do really need to be considering. I mean, we had a patient the other day who basically had like 98% stenosis once we sent them off to a Doppler because we saw ocular ischemic syndrome. So this is someone who is, just a squeeze of the neck away from a major stroke. Yeah. So don't forget this as a potential cause, and don't forget your carotids as being your main feeder to the eye. So if your eye is ischemic in nature, it may not necessarily be a microvascular problem. It could be a macrovascular problem. And that's really the point and the takeaway message here. So that's the session today. Please do give me your feedback again. Just scan this. The link is on the WhatsApp group and on the YouTube channel at the bottom of the description. There'll be links to the feedback. So I do really, really, really appreciate the feedback coming in. And it helps me sort of know how I'm pitching the sessions. And also from the feedback, there's another link to then give me suggestions as to what you want me to go through, which then helps me sort of plan the sessions as well.